On March 23, 2020, Johns Hopkins was reporting nearly 350,000 confirmed COVID-19 cases worldwide and more than 35,000 in the United States. Dr. Neera Ahuja is a hospitalist at Stanford. In the early days of the Northern California outbreak, she needed to see a PUI patient or person under investigation. As she applied her PPE, including a gown and mask, realization happened to her. I could be exposed. This patient turned out to be clear of the virus. But then she had another moment of truth.
And then imagine young faculty going into patient rooms that are COVID positive and having to do it day after day because they're on service for a length of time. And knowing also that, that person's infection may be getting worse or the viral replication may be increasing over the course of their hospitalization, potentially increasing exposure to that provider.
The response from her colleagues was exactly what you'd expect from selfless clinicians who take their Hippocratic oath seriously. But in times like these, it was also humbling and inspiring.
There hasn't been anyone that said, you know what, I'm not going to do this. In fact, they've said, are we safe enough? Are we gowning on properly? Are the masks the right thing to do? Should we build a COVID containment unit so that it's just a smaller number of providers caring for these patients and not exposing other providers that may be older or potentially pregnant, things like that?
Many healthcare workers across the country and indeed across the globe have had conversations about how they plan to handle the incoming storm of patients with COVID-19. In this episode, Medscape brings you that conversation, including what to do when colleagues develop symptoms, the PPE shortage, and how to handle students, residents, and fellows. This is Medicine in the Machine, an informational and conversational podcast about how technology is impacting medicine now and how it will in the future, featuring Dr. Abraham Verghese and Dr. Eric Topol. I'm a producer on the show, Nick Andrews. Normally at Medicine in the Machine, we bring you conversations that feature topics like artificial intelligence and EHRs. But as the groundswell of COVID-19 and the novel coronavirus explodes in the Western Hemisphere, we, like so many out there, are using our platform to provide information about the pandemic, specifically to the healthcare men and women in the trenches. In this episode, Dr. Abraham Verghese welcomes Dr. Neera Ahuja of Stanford University. Remember, there's a transcript of this conversation available wherever notes are found in your podcast app. Without any further delay, one of the hosts of Medicine in the Machine, Dr. Abraham Verghese.
It's my pleasure today to be speaking with a colleague, Neera Ahuja, who heads the hospital medicine division at Stanford University. And Neera, we're surrounded on every media avenue we turn to. We have experts pontificating about this and that. But I must tell you that my admiration has been for the frontline folks, and this must be true all across the country, but at our institution, it's the folks in the emergency room, it's the folks who receive the inpatients, namely your team. And so it's truly an honor to have you tell us that perspective. And also, I must say that, watching you the last few weeks mobilize for something that even though we may have some sense of what was coming, I don't think anybody truly could tell the dimensions that it might take. So delighted for you to join us. And I want to begin by asking you very simply, how are you? And how are you coping with what must have been an extraordinary couple of weeks?
Thank you, Abraham. Thank you for making the time to speak with me and kind of hear the stories that are going on both in the front line and, with those that are trying to help support everyone. I will say that I'm energized and exhausted. I had no idea, like you said, what we were walking into. And had I known it would be this hectic, I would have started preparing our teams and education and, training around all of this months in advance. But as it's known, we weren't quite aware of how fast this would come. Although I'm sleep deprived, I will say that the energy and the excitement of keeping things going and knowing that people need me to respond quickly has been, in a way, invigorating. And although I can't see them face to face like I used to because of the shelter-in mandates, I am periodically going to the hospital when I need to take care of some issues and trying to make sure that I do lay eyes on people when I can, because that eye-to-eye, face-to-face contact, even without words, is so much more powerful than a simple email or text.
Absolutely. And you're managing to I didn't mention this before, but also juggle family and young children all in the midst of this. I mean, frankly, I just don't know. Most of my women colleagues manage all this, but you more than anybody else.
Yes, and that's in large part to them understanding and respecting what I'm doing. They know how important this work is, and they know to kind of tiptoe around when I'm on a call. And my amazing husband has been greatly supportive.
Well, please thank all of them for being the support that they are to you. I want to sort of step back, and I'm sure that we'll be doing a lot of this in the years to come. But when you look at how you had to respond, first of all, the hospitalist movement in America has pretty much become the model, for the inpatient care of patients once they get past the emergency room. So walk us through the sort of timeline of how at various stages you've had to respond to the increasing realization that this thing we're talking about, COVID-19, is coming.
Yes, over the holidays, that's the November, December time, particularly in late December, we had a dramatic increase in our volumes. And it was almost the imperfect time to have such a situation because it's mostly skeleton crew and, people are focused on getting in, rounding, and getting home to their families for the holidays. And that started to make us a little more aware that, we need to make sure that we have adequate staffing should volumes increase with any type of COVID infection in the United States. And conversations started to happen over the course of January and escalate a little more in terms of, what would we prepare for in terms of wards, which wards would be the COVID-containing wards. But those conversations didn't really actualize until March. And as you know, we had, our cases only about 10 days ago, some of the first cases in our hospital, particularly as, the COVID reagent development and testing abilities became much more accessible due to the amazing work of Ben and his lab. And so it's almost like we were backtracking and thinking, did we have enough staff activated? Who else can we recruit in? And within the division, everyone has stepped up and said, I want to help. What can I do? I could even double cover 2 services, which has been nice. But we've already had a few providers who have taken care of COVID positive patients and then have symptoms. And so we have to be protective of them. So staffing has been one huge part of this that we're still evolving with. We are preparing for potentially how we would function if there was a 40% loss of staff. But in talking to some of my colleagues at other hospitals, they're already at that number and they're wondering, should they, look at 70% loss of staff. Some providers have young children who are no longer in school and they're having to stay home and take care of them. And so, they're rounding early in the morning, having their spouse cover the families and then rushing back home to take care of the children, being available via telemedicine or telephone. Some very unique rounding modalities. And fortunately, with the Stanford Act, we now have the ability to be more flexible and utilize telemedicine in the care of certain patients. In the inpatient setting, it's a little more challenging, but with CMS patients in the inpatient setting, every third day, a telemedicine visit is considered appropriate as long as the patient is stable. A few other things that we've had to look at is education. Now, and I know that you're so well aware of this given your large role in education at our institution, but, how has that been compromised and how can we compensate in a way that's meaningful? Instead of just sending modules their way and saying, review this on your own time, how can we make it effective and a dialogue in real time? And we do have a couple of apps that we're utilizing and tracking their usage so we know, how they did. And this is through the help of the Human Diagnosis app.
One of the things that was a bit controversial, as you know, was we decided to take medical students off the clerkships. And that happened, I think, a few days before the AAMC and the LCME and others came out with the same recommendation. But it was controversial. There was a sense that on the one hand, students needed to, experience this because this was the life that they were choosing. But then many of us felt strongly that we had a responsibility to them, and the educational imperative was quite overwhelmed and canceled out by the imperative to keep them safe. But I think it also came about because we're still so unsure about this virus. We're still unsure about having protective equipment. And, so maybe we can talk a little bit. I'd like to talk about two things with you. First, testing. It seemed like, unlike almost anything else that we were dealing with, the great difficulty was not knowing who had it and who didn't. And I'm sure this was mirrored all across the country. But talk a little bit, if you would, about the testing challenges, and then maybe we can get into the issue of personal protection.
Sure. So, initially, the testing criteria that were created were a little more strict or stringent. It was fever or influenza-like illness, sore throat, shortness of breath, body aches, myalgias, that sort of thing. But now it's become a little looser in the sense that if you're concerned they could have COVID positivity based on those symptoms, or adding cough, to that, you could just test. But there were some reagent shortages. And in fact, I today toured the lab that this is all done on the Hillview site. And I was touring it more because of our NIH site visit today as we do our remdesivir study. But what I learned was there has been an influx of people willing to help this lab to get more reagent, and other labs around the area have done what they can because they know how important the testing is. What we're also finding, though, is that we don't want to overtest. Now that Stanford was known to be a site of testing, the community thought, well, you know what, I've got symptoms, let me come to Stanford, let me come to my Stanford PCP. And so I think in the outpatient setting, there's been some very nice measures taken to sort of control and restrict testing to just those who need it. One interesting thing I learned in this process was this virus actually moves from proximal upper airway nasopharyngeal down to the lower lungs. And so the test is very sensitive, but if you catch it in a stage in which it's already progressed, you may have a false negative. And we actually did have an incidence of that, and it was originally falsely negative, and then in the bronchial secretions a couple of days later it turned out to be positive. With regards to the medical student question, this is a generation of learners that is so civic and social and wants to help. But I personally feel that we do need to protect them. They're also very vulnerable. And if illness incapacitates them, how can they continue on their, education trajectory and keep within the timelines, et cetera? So while I do agree with the decision that was made, what has been unexpected was how many students came out to help in other ways. They made proposals saying we can serve in capacities that may not be officially physician skills, but let us help with carrying supplies. Let us help with babysitting the children of faculty who are restricted from their work because their children's schools have closed down. And it's just been so touching to see the outreach from the medical student groups.
It truly has. It truly has.
You can read the transcript from this podcast and find more Medicine and the Machine episodes at medscape.com/machine. Medscape news, features, clinical tools, and education are available for free. Stay on the pulse of medicine. Visit medscape.com.
If we can switch to an issue that I think is very much on all our minds, we need to have the confidence walking in to see a patient that we're protected. On the other hand, we're not always certain who we're seeing has the virus or who is incubating and evolving. So talk a bit about how that imperfect knowledge translates into practicalities in terms of protecting the people who work with you and for you.
Yes. And, I think I had my moment of truth last Friday when I had to dawn on, that's, the proper terminology to describe putting on the PPE, the personal protective equipment, and, walking into the room of a patient with, quote, PUI, a person of under investigation for potential COVID infection. And this patient ended up being negative, but just as you're placing that mask and the gloves and the gown on, you have that sense of, I could potentially be exposed. And then imagine young faculty going into patient rooms that are COVID positive and having to do it day after day because they're on service for a length of time. And knowing also that, that person's infection may be getting worse or the viral replication may be increasing over the course of their hospitalization, potentially increasing exposure to that provider. And, I will say our hospitalist faculty have just stepped up to the plate. There hasn't been anyone that said, you know what, I'm not going to do this. In fact, they've said, are we safe enough? Are we gowning on properly? Are the masks the right thing to do? Should we build a COVID containment unit so that it's just a smaller number of providers caring for these patients and not exposing other providers that may be older or potentially pregnant, things like that. So just that sense of how do we protect ourselves as well as take care of the patients was a very nice, I think, common theme amongst everyone unifying in the care of COVID positive patients. The other aspect is, nationally there's a lot of talk about the PPE shortages. And while we don't want to overutilize the personal protective equipment, we want to make sure that we're adequately protecting our staff. And that conversation has been very loud on email, via text, via phone. And I think the institution is clearly addressing it, but it's, I was on a call the other day and there's a hospital in New York that said they have 71 COVID positive patients and only a 2-day supply of PPE. And so we're trying to learn from other institutions and countries how we can avoid getting there.
I think part of the problem is no one knows what the correct level of gowning and protection is. I mean, does one need a hazmat suit with a separate oxygen supply, or is that excessive? And in the absence of data, I think we're all kind of hoping and guessing. And also, we don't simply have that much equipment in this country to allow everybody to be so suited. Is that right?
Exactly. And we know that, there is aerosolization of the virus for potentially for a few hours. We also know that it lives longer on certain plastics and steel than it does on cardboard. And so, that we take all of that into consideration as we navigate through our environment. I'll tell you one really touching story of a nurse. There was a nurse who was going to be involved with the care of a patient, and he had a beard that he, had for many years. And the difference between the patients that we take care of and the patients that are, receiving airway treatments in the ICU or bronchoscopies is called CAPR. That latter kind of state would be a lot more protective equipment and hoods and just more expensive equipment. And this gentleman with the beard was going to have to use one of those, although it wouldn't have been needed, but just because of the mask not fitting his bearded face properly. And he actually went to the bathroom, shaved his beard, and came out and said, I don't want to overutilize any equipment. We need to preserve everything we can. And it's just stories like that I find truly amazing because I think people get it.
I think what's lovely to watch, and I think this is probably true across the country, is that most hospitalists tend to be younger folks. This is in comparison to me. I'm 65 this year.
Right.
But it does seem to me many of these folks are my former trainees who are now, assistant and associate professors. But it's a generation of younger folks, and in many ways, this is your HIV era, if you like, or your HIV moment. And it's just wonderful to see how they're stepping up. Would you share with us one of your hardest moments? I know you just shared one of the nice moments that was about somebody else, but share with us one of your hardest moments and one of your nicest, most uplifting moments in this last few weeks.
Sure. I think one of the hardest moments was when a faculty member said that she felt there needed to be more guidelines around what we're wearing, and that potentially in her mind we should be wearing masks even as we're walking through the hospital because of this aerosolization risk. And even though we're not walking into a COVID positive patient's room, how can we say for certainty that there's not the virus hanging around? And just knowing that the mandate from, not only our hospital, but every hospital is that we need to preserve PPE, not wear it unnecessarily. The CDC guidelines do not require that we wear it when we're walking around, as long as we're not infected. And having to say, I hear you, but I want you to use your best judgment along with what the protocol says. And that was my sort of wink to her, saying that I hear you, I understand you, do what you think is best, but we're not supposed to overutilize. And I felt very conflicted because what she was clearly telling me is I want to walk around with a mask, and I want my colleagues to walk around with a mask. I don't want to lose anyone, to this illness, either just by 2 weeks of sickness or something more serious. And that is actually still something I'm struggling with because those conversations are so prevalent even now. And then I think one of my, brightest moments, there have been a lot, but I think the philanthropy that has come in from so many different sites. I've had people that I barely know reach out through just Googling, Stanford Hospitalist and say, how can we help? What can we donate? What do you need? Today we had a restaurant in San Francisco reach out to one of our colleagues saying, we want to deliver food to the physicians. 2 days ago, we had someone on standby to deliver well over 1 million sources of PPE and 95 masks. So those types of stories are really what keep us going, and realize that we are one big community going through this together, and everyone's trying to help out in the way that their education, their business, and their heart lets them.
Neera, you're a leader in hospital medicine nationwide and publish a lot. And I just got a call from somebody in Nevada who I don't know very well, but at a small hospital as a hospitalist, asking what might they do. What advice would you give to places that perhaps are maybe a week or two behind us in terms of the arrival of the numbers that we are seeing or expect to see in our community? What are some things that they might start doing systematically to be prepared on the hospital medicine service?
Yes. No, great question. Sort of what I wish I knew 2 months ago or 2 weeks ago. I think one is start staffing up providers, train them for PPE and emotionally prepare them for what's to come. They may be sleep deprived. They may be stressed in how to handle that. And I think what I'm also learning through this process is we need to carve out time for sleep and for connecting with our families. So I would tell them that's important. I think a lot of focus on, if it's an academic medical center, on how to educate the vulnerable younger trainees and learners in a way that's effective. Utilizing telemedicine and getting that infrastructure set up would be key. And then, as we launch our NIH study on remdesivir, we are doing this very fast track because of just the timeline of all of this, but try to prepare for what things you can study both in a quality improvement and patient safety realm, as well as clinical trials. We have so many ideas coming through now, and it's often as an incident happens and someone reflects on, well, why did that happen? What could we have done better? Oh, we should perhaps study this. I think being a little more prospective will help get the groundwork done so that these studies could move faster and more can be built on top of them.
So, Neera, we couldn't have asked for a better overview of what things look like from your point of view. And I think speaking for hospitalists everywhere, I thank you for being so generous with your time, because I have no doubt that you're going right into something else after this. And I also, thank you on behalf of our Medscape audience, who I think would be anxious to hear your perspective, and you really have a unique perspective. My suggestion is
Thank you, Abraham,
to take good care of yourself, okay?
Will do, and thank you for your time and getting the stories out there. Thank you to the entire Medscape team.
Thank you so much.